Hello everyone. Today I'm going to talk about top differential diagnosis of acute myocardial infarction in imaging. First of all, I would like to review about the acute myocardial infarction in the imaging. So what is the clue? Acute infarction, it means the feeling defect on invasive coronary angiogram plus warm motion abnormality in corresponding myocardial segment and increased myocardial enzyme. Cognitive location, acute myocardial infarction divided in first one, left anterior descending coronary artery infarction, anterior and subthalamic segment extend to or apical inferior wall. Proximal left anterior descending coronary artery. It starts from proximal to first septal perforator, mid left anterior descending coronary artery. It starts from distal to first septal perforator, proximal to large diagonal. Distal left anterior descending coronary artery start from distal to large diagonal. Left ventricular infarction usually involve inferior septum and right ventricular inferior free wall to great extent than anterior wall. More than 90% due to RCA occlusion with small percentage due to circumflex occlusion in patients with left dominant circulation. Left ventricular involvement depends on dominant of circulation. RCA infarction. Lateral segment of left ventricle. According to size and morphology, acute myocardial infarction divided. According size, more proximal the lesion, larger the infarct. More distal stenosis may be accounted by collateral coronary arterial supply and deficient vein supply. Morphology infarct start within subendocardium and progress toward to subepicardium. Non-transmural infarct does not involve full sickness, spare subepicardium. Ischemic necrosis is limited to subendocardium. Extent of necrosis is variable, typically associated with non-acute valve infection. Transmural infarction involve entire myocardial wall. In radiograph, acute myocardial infarction usually rare. There is any abnormality in the X-rays. But if it caused the heart failure, so we can find the sign of interstitial edema, abnormal cardiac silhouette. If chain may res- this chain may result from heart failure to or acute mitral valve dysfunction, but heart cause do not occur in acute phase. Right ventricular enlargement is best appreciated on lateral view. Sudden severe pulmonary edema in papillary muscle rupture with mitral regurgitation. This is poor prognosis. In CTA, not typically used for diagnosis of acute myocardial infarction. Infarction may be incidentally detected on CT performed for other causes, for example, evaluation of aortic dissection. Coronary occlusion with non-calcified material, often extensive positive remodeling. May it may demonstrate hypotension subendocardium in vascular territory, less than 50% attenuation of normal myocardium. 5 mm 6 MPR or 5 mm minimum intensity projection. Multiphasic sign. Assessment of ventricular global regional function and dilatation. Ejection fraction and ventricular volume can be quantified with volumetric stress or based or model-based software algorithm. Reservoir sickness, wall thickening, and presence of calcification fatty metaplasia are the signs of chronic myocardial infarction. Cardiac CTA sensitive around 90 to 90% for detect of hemodynamically significant right coronary artery stenosis using 64 slide greater CT. Coronary CTA has high sensitivity 98%, specificity 88%, and negative predictive value around 95 to 100 for detection of hemodynamically significant stenosis. Delay enhanced CT may be visible but display poor contrast to noise ratio as compared with MRI. May evaluate viability of myocardium. CT viability required to scan conventional CTA and then delay scan to identify late contrast hyperenhanced of myocardium. In, sit, in setting of acute myocardial infarction, loss of membrane integrity, and case volume distribution of contrast. In chronic scar tissue, mosaic relapse to with sorry collagenous matrix resulting in increased interstitial space. Both processes lead to hyperenhanced or delayed image. CT perfusion. Post-fast perfusion has stress and rest, underestimate infarct as compared with late calodinium enhancement MRI. Anterior and anterosubtalar myocardial perfusion effect. This image shows multi-planar reconstruction of contrast-enhanced CT transstructure orientation, 8 millimeter thickness, so a clearly defined hypoperfusion of the lateral wall of the left ventricle. Black solid arrow indicate this is the apparent of acute myocardial infarction. ST segment elevation MI STEMI or non ST segment elevation MI non STEMI on contrast enhanced CT. This image shows contrast enhanced coronary CTA in the same patient reveal occlusion of the intermediate brain ramus Y solid arrow indicate. This image shows axial CT in the same patient demonstrate normal wall thickness with subendocardial low attenuation perfusion defect. Y solid arrow indicate in the left anterior laterally. The image shows this is multi-planar reconstruction, contrast enhanced CT for chamber view, 8 millimeter thickness, so acute non-STEMI, typical subendocardial hypoperfusion, black solid arrow indicate of the left posterior lateral myocardium is seen. This is short axis contrast enhanced CT of the left ventricle in the same patient shows subendocardial perfusion black solid arrow of the left posterior posterolateral myocardium with preserved wall thickness. Note the involvement of more than 50% of the wall, suggesting low probability of function recovery after revascularization. This oblique for the left ventriculogram in asystolic so agenesis of left ventricular anteroapical wall. Wide open arrow indicate due to acute myocardial infarction in the left anterior descending coronary artery territory. This oblique coronary CTA show occlusion of the distal right coronary artery while curved arrow indicate with a calcified and non-calcified plaque thrombus distal to the occlusion. This oblique cardiac CT for the left ventricular show normal left ventricle cavity in end-diastole. OI T2WI. We will see increased signal intensity due to myocardial edema. Edema typically larger than infarction, may have wall thickening due to edema. This black bloodshot axial T2 show transmural high signal of the left anterior black open arrow indicate an anterosubtal white open arrow indicate myocardial segment consistent with acute myocardial edema in the large vascular territory. Note: anterosubtal segment hypertrophy secondary to edema. This corresponding early image shows an essentially transmural impact of the left ventricle anterosubtal segment. Black solid arrow indicate note that the LE area is smaller than the two high signal area, indicating large area at risk on T2 sequence. The short axis T2 of an inferior subtle and right ventricular infarction show abnormal increased signal of the inferior left ventricle and inferior septum. Y curve arrow indicate with extension to involve the inferior right lateral wide open arrow indicating that the myocardial infarction is acute. Some more sign. It is standardized 17 segment. It is standardized and gold standard for functional assessment, ejection fraction, left ventricle and diastolic systolic volume, left ventricle mass. Decrease regional wall motion and systolic wall thickening. Decrease ejection fraction, but could be preserved due to compensation from remote myocardium. Diminished right ventricle function is common in patients with inferior myocardial infarction. Evaluation of right ventricle function prognostic indicate may demonstrate mitral valve regurgitation in if inferior myocardial infarction in both posterior papillary muscle. The short axis of all sign in systole show an area of hypokinesis in anterior and anterosubtle were associated with increased myocardial signal. Y curve arrow indicate edema indicating acute myocardial infarct, not pericardial effusion. The short axis native T1 in a 57 years old patient with acute chest pain, high troponin level, and normal coronary artery on invasive angiography. So elevated native T1 value at the mid inferolateral segment, which is also found to have severe hypokinesia. First, past perfusion. Previous find reduced worsening of contrast agent, perfusion deficit in coronary territory involving subendocardium, both at rest and stress. The short axis G2 first pass perfusion, SSFP, and LGE in the same patient demonstrate edema, black open arrow, Subendocardial perfusion effect black solid arrow and LGE wide open arrow, but no more sickness anterior subtle left ventricle wall consistent with acute myocardial infarct. Note inferior chronic myocardial infarct and ventricular thrombus wide curve arrow. The short axis first pass perfusion of also matching hypoperfusion in the anterior and anterior-subtal wall Y-curve arrows, suggesting microvascular obstruction. Delay enhancement in CT has ability to detect 1G of inversibility damaged tissue, vary inversion time to maximize nulling of normal myocardium, right ventricle GI is often slightly shorter than left ventricle GI. Demonstrate present location and extension of MRI. Degree transmorality of late calodinium enhanced determines viability. Very low anterior server reliability, excellent reproducibility. These left ventricle short axis late calodinium and hand all demonstrate sub-endocardial non-transmural delay hyper-enhancement Y curve arrow indicate on the undivided normal black left ventricle myocardium consistent with non-transmural infarct in the left anterior descending coronary artery territory, not normal wall sickness, which is typically seen in the acute setting. The short axis SSFP also high signal of edema indicate of acute lab territory MI, Y curve arrow and wall thinning with subendocardial late caloric hand indicate of chronic right coronary artery territory MI. Y open arrow indicate image was obtained after calorium administration prior to late calorium enhanced exquisition. This corresponding RE two chamber cardiac also an extensive acute transmural infarct affecting the basal, mid, and apical anterior myocardial segment. Wide open arrow indicate large territory. Note multiple low signal moral nodule. Wide solid arrow consistent with moral thrombus. Note different location compared with microvascular obstruction which occur within the myocardium. The short axis late calodinium and hence also more than 50% subendocardial enhancement in the left ventricular septum. There is non-enhancing myocardium by curve arrow that correct that represent no reflow of microvascular obstruction. The short axis late calodinium enhanced also subendocardial enhancement, black solid arrow, with the lateral wall in the lateral wall of the left ventricle. The transmorality of the enhancement is about 50%, suggesting a fair probability of functional segment recovery following revascularization. Short-axis LGE also abnormal enhancement signifying infarction of the inferior right ventricle and inferior septum Y-curve arrow indicate with extension to the inferior right ventricle Y open arrow indicate. Note that the right ventricle free wall anteriorly demonstrate no evidence of infarction Y solid arrow. Short axis LGEMO in the same patient demonstrate the subendocardial LGE more than 50% of the wall at the same region, finding are consistent with acute MI in the LCH territory. A near total occlusion of an obtuse marginal brain in retrospectively identify on pre-MO angiography image, confirming MO finding. The short axis LGD-MO show a large area of hyperenhanced. White solid arrow indicate in the inferior wall represent myocardial necrosis with a central area of hypoenhancement. White open arrow indicate microvascular obstruction. Short axis LGEM also hyperenhanced consistent with myocardial necrosis in the anterior and anteroseptal wall. White curve arrow indicate in the setting of the anterior acute myocardial infarction. Parametric map, promising technique to qualify actual MI sign. Pre and post contrast C1 value are found to accurately quantify acute MI sign. May also estimate area at risk. This color map of native T1 in the same patient show the elevated T1 value at the mid inferior lateral wide open arrow segment compared to the rest of myocardium. Native T1 mapping allow the evaluation of the infarction without administration of the contrast. This T2 color map the same patient show the high T2 value, Y solid arrow of the same segment consistent with myocardial edema. Role of MR in myocardial infarction, diagnosis and differentiation of acute MI. In case with subtle clinical symptom, establish diagnosis for ST elevation with normal coronary artery on angiography, myocarditis, etc. In case with spontaneous recanalization of coronary artery stenosis, recognition of silent MI has been shown to be of value in research, ruling out ACS and aortic dissection acute PE, acute myocarditis demonstrate culprit lesion in multi-vessel disease. Determination of infarct, evaluation of reversible versus irreversible injury, evaluation of viability, transmorality, identification of microvascular obstruction, identification of hemorrhage in core of infarct, prediction of response to therapy, and guidance to partial good modality to assess MI complication. Echocardiographic finding. It is either global or regional myocardial function. A decrease in global ventricular ejection fraction is possible, but global function may be preserved. Chronic impact appear bright due to fatty replacement with worsening. Right ventricle myocardial infarction. We can find right ventricle dilatation, right to left shunt resulting from elevated right ventricle pressure, paroxysmal motion of interventricular septum. Doppler tricuspid regurgitation or mitral regurgitation decrease in systolic velocity, worse prognosis. Useful bedside exam for complication of acute MI, exclude tamponade constrictive pericarditis. This modified apical chamber view of acute apical MI on echography show normal apparent of cardiac activity in diastolic. Its corresponding image in systole show an akinetic area in the apical region of the left ventricle due to acute myocardial infarction, presence of new regional or motion abnormality in one of the diagnostic criteria for acute infarct. Angiography, occluded coronary artery, patent but stenocoronary coronary artery or plaque disruption, major evidence of thrombus, clinical gold standard for detecting coronary artery stenosis in high-risk patients and guiding percutaneous procedure. Ventriculography, reduce regional wall motion and ejection fraction. This is invasive coronary angiogram, so acutely occlusive proximal segment line, black solid arrow, not acute thrombus, black open arrow in the lumen. Top differential diagnosis. First one, unstable angina, aortic dissection, pulmonary embolism, acute myocarditis, acute pericarditis, trans, black ventricular apical ballooning, pulmonary embolism. To the what is the first difference? The first differential diagnosis with acute myocarditis is chronic myocardial infarct. So what is it? Wall motion will be abnormal, persistent hyper-enhancement or absent tracer uptake on scintigraphy, no peri-infarct signal increase on T2 amount, symbol calcification, fat metaplasia, aneurysm. So this is axial cardiacity, so sinning and aneurysmal dilatation of left ventricular pipe. Why solid arrow indicate remote transmural myocardial infarcts in the left anterior descending coronary artery territory. This left ventricular short axis delay enhancement also hyper enhancement in of the right ventricle, like solid arrow indicate, and left ventricular inferior Y solid arrow indicate, and inferior wall which have developed a large aneurysm Y open arrow not be an enhanced moral thrombus. Unstable angina. It is acute coronary syndrome without myocardial necrosis, isolating a crescendo pattern of chest pain at rest. Normal cardiac enzyme, significant signals by angiography, or positive test for myocardial ischemia. A. T2-weight black blood short systemic through the mid-left ventricle so increase T2 signal intensity throughout the mid-myocardium. B. Short axis led calodinium enhanced image demonstrate marked enhancement in a mid-myocardial distribution on quantitative analysis. 48% of the left ventricle demonstrate led calodinium enhancement. Acute myocarditis in clinical will be chest pain, increased cardiac enzyme, normal coronary artery. MRI in fundamental for diagnosis, for edema, and led calodinium enhanced in non-vascular territory. While motion abnormality may be associated, cell membrane integrity is compromised. Affects subepithelium rather than subendocardium. This T2, this T1C plus among demonstrate Hetchy early enhanced in lateral left ventricle while solid arrow indicate consistent with hyperemia due to myocarditis. This pattern is less typical. Usually there is global T1 signal increase which can be visually inapparent and need to be quantified. Axial T1C plus or have identical slide position with Roy drawn over identical location in the left myocardium and skeletal muscle is used to calculate the global relative enhancement ratio positive is more than 4. The degree of myocardial relative hyperenhancement is one criteria toward the diagnosis of myocarditis. Acute pericarditis, acute chest pain, ECG change that are very similar to MIs, ST segment elevation possible. Myocardial enzyme remain normal unless myocardium is involved in permanent process. Pericardial thickening, effusion, and enhance in amount. These are shear contrast intensity of a patient with acute myocarditis, so thickening and enhancement of both visceral like solid arrow indicate and the parietal Y solid arrow indicate pericardial layer separated by peripheral diffusion. Viral disease is the most common cause of infectious pericarditis. This axial contrast enhanced CT, a patient with HIV and tuberculosis pericarditis so diffuse thickening on an enhancement of pericardial layer, sign and solid arrow, and pericardial and bilateral pleural effusion, YO pen arrow indicate the pericardial drain in the place. Tuberculosis pericarditis may occur without pulmonary symptoms, particularly in HIV population. Coronary spasm, prenatal angina, syndrome of chest pain at rise secondary to migraine ischemia associated with ST segment elevation. Stress-induced cardiomyopathy. It is cardiomyopathy, reversible left ventricle dysfunction with right apical akinesia, pattern of severe Takotsubo or mid-ventricle Takotsubo are possible but infrequent. Normal coronary artery on invasive angiography often preceded by traumatic emotional experience. Left ventricle function return to normal within subgroup. Slight increase of myocardial in enzyme is possible. Among we can find edema may be present, no late calorium enhanced alcohol. This is vertical long assist sign on all in systole, so a pickup pattern of strike myocardial cardiomyopathy, which agenesis of the mid to apical left ventricle, while solid arrow indicate a normal contraction of the basal left ventricle, while open arrow indicate two-chamber CT dual systole. So severe hypokinesis of left ventricle apex, while solid arrow, with preserved contractility of the base to midlife and the cross segment consistent with stress-induced cardiomyopathy. Pulmonary embolism, chest pain, right heart failure, and clear lung on chest day. Axial CTA, same patient, so atrial filling defect consistent with pulmonary embolism. Axial pulmonary CTA, so extensive right interlobar and bilateral lobar pulmonary arterial filling It might be associated with extension of involuntary artery segment, consistent with acute pulmonary embolism. Thank you.